100 Essential Question and Answers. Respiratory Physics and Physiology and Anesthesiology. Welcome back to the Everything Surgery podcast. Today we look at 100 Essential Question and Answers. Respiratory Physics and Physiology and Anesthesiology. Pause the video when you hear the word answer to attempt answer. Let's dive in. Section 1. Gas laws and physics question. State Boyle's law and its relevance to anesthesia. Answer. Boyle's law states that pressure multiplied by volume remains constant at constant temperature. In anesthesia, this law explains gas compression in cylinders, such as oxygen stored at 2,000 pounds per square inch expanding when released, as well as lung mechanics during ventilation. Question. How does Charles' law affect anesthesia machines? Answer. Charles' law claims that volume is proportional to temperature at constant pressure. This means vaporizers must compensate for temperature to ensure proper delivery, as anesthetic agents expand when heated. Question. Why is nitrous oxide stored as liquid in cylinders? Answer. Nitrous oxide has a critical temperature of 36.5 degrees Celsius, which is higher than room temperature. Therefore, it liquefies under pressure, unlike oxygen which is stored as a compressed gas. Question. Define latent heat of vaporization. Answer. Latent heat of vaporization is the energy required to convert 1 gram of a liquid into vapor. For example, sevoflurane requires 160 kilojoules per kilogram. This process explains cooling observed in vaporizers. Question. What is the second gas effect? Answer. The second gas effect occurs when rapid uptake of nitrous oxide increases the alveolar concentration of a co-administered volatile anesthetic, such as halothane. Question. How does Dalton's law explain hypoxia at altitude? Answer. Dalton's law states that total pressure decreases at altitude, but the fraction of inspired oxygen remains constant. As a result, the partial pressure of oxygen in the alveoli falls. For example, at 5,000 meters, the atmospheric pressure is 405 millimeters of mercury, resulting in a partial pressure of oxygen of about 85 millimeters of mercury. Question. How is oxygen content in blood calculated? Answer. Oxygen content is calculated by the formula 1.34 multiplied by hemoglobin concentration multiplied by oxygen saturation, plus 0.003 multiplied by partial pressure of oxygen. The normal value is approximately 20 milliliters of oxygen per deciliter. Question. Why does carbon dioxide diffuse 20 times faster than oxygen? Answer. Carbon dioxide diffuses faster due to its higher lipid solubility, even though its partial pressure gradient is lower. Question. What is the Reynolds number and its clinical significance? Answer. Reynolds number predicts whether flow is turbulent or laminar. It is calculated by multiplying density, velocity, and diameter, and dividing by viscosity. When Reynolds number exceeds 2000, the flow becomes turbulent, as occurs when an endotracheal tube is kinked, dramatically increasing resistance. Question. How does Poiseuille's law impact airway resistance? Answer. Poiseuille's law shows that resistance is inversely proportional to the fourth power of the radius. Thus, a 50% reduction in endotracheal tube diameter increases resistance 16-fold. Question. Define Fick's law of diffusion. Answer. Fick's law states that the rate of gas diffusion is proportional to the surface area, pressure difference, and solubility, and inversely proportional to the square root of molecular weight and distance. This explains why carbon dioxide diffuses faster than oxygen and nitrogen. Question. What is Graham's law? Answer. Graham's law states that gas diffusion rate is inversely proportional to the square root of molecular weight. This explains why helium, which has a low molecular weight, reduces airway resistance. Question. Why does nitrous oxide cause diffusion hypoxia? Answer. Upon discontinuation, nitrous oxide rapidly diffuses into alveoli, diluting the oxygen concentration and causing temporary hypoxia. Question. How is the duration of an oxygen cylinder calculated? Answer. The duration in minutes is calculated by multiplying the pressure in pounds per square inch by the cylinder factor, and dividing by the flow rate in liters per minute. Question. What is the Joule-Thomson effect? Answer. The Joule-Thomson effect describes the cooling of a gas when it expands, a principle utilized in cryoanalgesia. Question. Define minimum alveolar concentration and factors that affect it. Answer. Minimum alveolar concentration is the minimum concentration of an inhaled anesthetic required to prevent movement in 50% of patients. It decreases with opioid use, increasing age, and hypothermia, and increases with hyperthermia and central nervous system stimulants. Question: how does altitude affect minimum alveolar concentration? Answer: the minimum alveolar concentration, measured as partial pressure, does not change at altitude, but the delivered percentage must be increased since atmospheric pressure is reduced. Question: what is the Meyer-Overton rule? Answer: the Meyer-Overton rule states that anesthetic potency is proportional to lipid solubility. A higher oil-to-gas partition coefficient means greater potency. Question: why does desflurane require a heated vaporizer? Answer: desflurane has a low boiling point of 23.5 degrees Celsius, requiring a heated vaporizer to maintain stable vapor pressure. Question: how does soda lime absorb carbon dioxide? Answer: soda lime absorbs carbon dioxide through a chemical reaction. Carbon dioxide combines with water to form carbonic acid, which then reacts with sodium hydroxide to produce sodium carbonate. Water and heat. A dye indicator, such as ethyl violet, turns purple when the soda lime is exhausted. Section 2. Lung mechanics and volumes. Question: what is compliance and how does anesthesia affect it? Answer: compliance is the change in volume divided by the change in pressure. Under anesthesia, compliance decreases due to atelectasis, reduced functional residual capacity, being in the supine position, and muscle relaxation. Question: what is functional residual capacity and its normal value? Answer: functional residual capacity is the volume of air remaining in the lungs at the end of expiration. The normal value is approximately 30 milliliters per kilogram or 2.5 liters in adults. Question: why is functional residual capacity important in anesthesia? Answer: functional residual capacity acts as an oxygen reservoir during periods of apnea, preventing rapid desaturation. A lower functional residual capacity increases the risk of atelectasis. Question: how does anesthesia reduce functional residual capacity? Answer: anesthesia decreases functional residual capacity by 15 to 20% due to loss of respiratory muscle tone, the supine position, and atelectasis. Question: what is closing capacity and when does it become a problem? Answer: closing capacity is the lung volume at which small airways begin to collapse. In young adults, it is normally less than functional residual capacity. When closing capacity exceeds functional residual capacity, as seen in older adults or individuals with obesity, it leads to ventilation-perfusion mismatch. Question: how does laminar flow compare to turbulent flow in the airways? Answer: laminar flow occurs at Reynolds numbers less than 2000 and is typical in peripheral airways, resulting in quiet airflow proportional to pressure difference. Turbulent flow occurs at Reynolds numbers above 2000 and is often noisy, such as when the endotracheal tube is obstructed, with flow proportional to the square root of the pressure difference. Question: what is the time constant and its clinical significance? Answer: the time constant is resistance multiplied by compliance. In healthy lungs, it is about 0.5 seconds. It increases in chronic obstructive pulmonary disease due to slow emptying, and decreases in acute respiratory distress syndrome where the lungs are stiff. Question: what is autopositive end expiratory pressure and what causes it? Answer: autopositive end expiratory pressure is incomplete expiration leading to air trapping. It can be caused by asthma, chronic obstructive pulmonary disease, high respiratory rate, or inverse inspiration to expiration ratio. Question: how does positive end expiratory pressure improve oxygenation? Answer: positive end expiratory pressure improves oxygenation by recruiting collapsed alveoli, increasing functional residual capacity, and reducing intrapulmonary shunt. Question: what is work of breathing and its components? Answer: work of breathing is the energy required for ventilation. It consists of elastic work, comprising 75% and involving lung and chest wall recoil, and resistive work, comprising 25% and involving airway resistance. Question: how does obesity affect respiratory mechanics? Answer: obesity decreases functional residual capacity due to increased abdominal pressure, increases airway resistance, and increases the work of breathing. Question: define dead space and its types. Answer: dead space refers to ventilated areas that are not perfused. Anatomic dead space includes the conducting airways, which average around 150 milliliters. Alveolar dead space consists of non-perfused alveoli, as seen in pulmonary embolism. Physiologic dead space is the sum of anatomic and alveolar dead space. Question: how is physiologic dead space calculated? Answer: Physiologic dead space is calculated using the Bohr equation. The difference between arterial carbon dioxide partial pressure and expired carbon dioxide partial pressure divided by arterial carbon dioxide partial pressure. A normal value is less than or equal to 0.3. Question: what is the alveolar ventilation equation? Answer: alveolar ventilation is calculated as respiratory rate multiplied by tidal volume minus dead space. This equation determines arterial carbon dioxide partial pressure. Question: how is arterial carbon dioxide partial pressure related to alveolar ventilation? Answer: arterial carbon dioxide partial pressure is directly proportional to the rate of carbon dioxide production divided by alveolar ventilation. Hyperventilation decreases arterial carbon dioxide, while hypoventilation increases it. Question: what is the Herring-Brewer reflex? Answer: the Herring-Brewer reflex is a vagally mediated inhibition of inspiration that occurs when the lungs are inflated, preventing overdistension. Question: how does pregnancy alter respiratory physiology? Answer: pregnancy increases minute ventilation due to progesterone, decreases functional residual capacity as the uterus displaces the diaphragm, and increases oxygen consumption. Question: what is airway resistance and its normal value? Answer: airway resistance is the pressure required to achieve airflow. The normal value ranges from 0.5 to 2 centimeters of water per liter per second, and increases in asthma or when the endotracheal tube is kinked. Question: define transpulmonary pressure. Answer: transpulmonary pressure is the difference between alveolar pressure and pleural pressure, determining lung expansion. Question: what causes decreased lung compliance? Answer: decreased lung compliance is caused by pulmonary fibrosis, acute respiratory distress syndrome, atelectasis, or pulmonary edema. Section 3. Ventilation perfusion and gas exchange. Question: what is the normal ventilation perfusion ratio? Answer: the normal ventilation perfusion ratio is approximately 0.8, which is calculated by dividing alveolar ventilation of 4 liters per minute by pulmonary perfusion of 5 liters per minute. Question: what causes a ventilation perfusion ratio less than 1, also known as shunt? Answer: causes of a shunt include absolute conditions such as atelectasis and pneumonia, or relative conditions such as pulmonary edema and acute respiratory distress syndrome. Question: why does 100% oxygen not correct shunt hypoxia? Answer: in shunt hypoxia, blood bypasses ventilated alveoli and does not absorb oxygen, so increasing the fraction of inspired oxygen cannot resolve the condition. Question: what causes a ventilation perfusion ratio greater than 1, also known as dead space? Answer: dead space can be caused by pulmonary embolism, hypotension, or emphysema. Question: what is the alveolar arterial oxygen gradient and its normal value? Answer: the alveolar arterial oxygen gradient is the difference between the partial pressure of oxygen in the alveoli and in the arterial blood. On room air, a normal gradient is 10 to 15 millimeters of mercury, and it increases in cases of ventilation perfusion mismatch and diffusion defects. Question: how does hypoxic pulmonary vasoconstriction improve oxygenation? Answer: hypoxic pulmonary vasoconstriction redirects blood flow to ventilated areas of the lung, thereby improving oxygenation. Question: what are the effects of anesthetic agents on hypoxic pulmonary vasoconstriction? Answer: volatile anesthetic agents inhibit hypoxic pulmonary vasoconstriction, with isoflurane having a greater effect than sevoflurane, and sevoflurane greater than desflurane. Question: how is alveolar oxygen partial pressure calculated? Answer: alveolar oxygen partial pressure is calculated using the alveolar gas equation. Inspired oxygen fraction multiplied by the difference between atmospheric pressure and water vapor pressure, minus arterial carbon dioxide partial pressure divided by respiratory quotient. Question: what is P50 and its normal value? Answer: P50 is the partial pressure of oxygen at which hemoglobin is 50% saturated. The normal value is 27 millimeters of mercury. This value increases during a rightward shift of the oxygen dissociation curve, such as during acidosis or fever. Question: what factors cause shifts in the oxygen dissociation curve? Answer: a rightward shift, which favors oxygen unloading, is caused by increased carbon dioxide, decreased pH, increased temperature, and increased 2,3-phosphoglycerate. A leftward shift, which favors oxygen binding, is caused by decreased carbon dioxide, increased pH, decreased temperature, or fetal hemoglobin. Question: How is carbon dioxide transported in the body? Answer. Approximately 70% of carbon dioxide is transported as bicarbonate through the action of carbonic anhydrase, 23% as carbamino compounds, and 7% dissolved in plasma. Question. What is the Haldane effect? Answer. The Haldane effect states that deoxygenated hemoglobin binds more carbon dioxide than oxygenated hemoglobin, enhancing carbon dioxide unloading in the lungs. Question. How does hyperventilation affect oxygen delivery? Answer. Hyperventilation lowers arterial carbon dioxide, causing a leftward shift in the oxygen dissociation curve. This increases hemoglobin's affinity for oxygen, which can reduce oxygen unloading to tissues. Question. What is the partial pressure of oxygen to fraction of inspired oxygen ratio in acute respiratory distress syndrome? Answer. The ratio of arterial oxygen partial pressure to inspired oxygen fraction is used to grade respiratory distress. 300 is normal. 200 to 300 indicates acute lung injury, and less than 200 is diagnostic for acute respiratory distress syndrome. Question. Why does end-tidal carbon dioxide decrease during pulmonary embolism? Answer. In pulmonary embolism, increased dead space leads to reduced carbon dioxide excretion, causing end-tidal carbon dioxide to fall despite a normal arterial carbon dioxide partial pressure. Question. How is oxygen delivery calculated? Answer. Oxygen delivery is calculated by multiplying cardiac output by the sum of hemoglobin concentration multiplied by 1.34, multiplied by oxygen saturation, plus 0.003 multiplied by arterial oxygen partial pressure. The normal oxygen delivery is about 1000 milliliters per minute. Question. What are the causes of an increased alveolar arterial oxygen gradient? Answer. An increased gradient may result from shunt, ventilation perfusion mismatch, diffusion impairment, or a right-to-left cardiac shunt. Question. What is the Fick principle regarding oxygen consumption? Answer. The Fick principle states that oxygen consumption equals cardiac output multiplied by the difference between arterial and venous oxygen content. Normal oxygen consumption is 250 milliliters per minute. Question. How does positive end expiratory pressure affect ventilation perfusion matching? Answer. Increasing positive end expiratory pressure helps recruit alveoli and reduces shunt, but may increase dead space. Question. What are the mechanisms of oxygen toxicity? Answer. Oxygen toxicity results from the formation of reactive oxygen species, leading to acute respiratory distress syndrome in the lungs, seizures in the central nervous system, and retinopathy in the eyes. Section 4. Clinical applications. Question. What are the indications for positive end expiratory pressure? Answer. Positive end expiratory pressure is indicated when the ratio of arterial oxygen partial pressure to inspired oxygen fraction is less than 300, for atelectasis, or for acute respiratory distress syndrome, typically at 5 to 15 centimeters of water. Question. How is autopositive end expiratory pressure managed? Answer. Management includes reducing respiratory rate, increasing expiratory time, administering bronchodilators, and lowering minute ventilation. Question. What is the difference between pressure control and volume control in mechanical ventilation? Answer. Pressure control ventilation uses a decelerating flow pattern and is better for lungs with inhomogeneous disease, while volume control guarantees a set tidal volume but may increase the risk of barotrauma. Question. What is the acute respiratory distress syndrome network protocol? Answer. The protocol recommends low tidal volume ventilation at 6 milliliters per kilogram predicted body weight, plateau pressure less than 30 centimeters of water, and permissive hypercapnia. Question. What are the types of ventilator-associated lung injury? Answer. There are 4 main types: barotrauma, volatrauma, atelectrauma, and biotrauma. Question. What are the benefits of high-flow nasal cannula oxygen therapy? Answer. High-flow nasal cannula oxygen therapy can deliver up to 100% inspired oxygen, provides a positive end expiratory pressure effect of around 5 centimeters of water, and washes out carbon dioxide from the upper airway. Question. What are the risks of excessive oxygen administration? Answer. Risks include absorption atelectasis, formation of reactive oxygen species, and reduced hypoxic pulmonary vasoconstriction. Question. What is the fraction of inspired oxygen delivered by a non-rebreather mask? Answer. A non-rebreather mask delivers 60 to 80% inspired oxygen at flow rates greater than 10 liters per minute. Question. What are contraindications for nitrous oxide use? Answer. Nitrous oxide should not be used in cases of pneumothorax, bowel obstruction, pulmonary hypertension, or during middle ear surgery. Question. What are the limitations of pulse oximetry? Answer. Pulse oximetry may be delayed during hypotension, inaccurate with abnormal hemoglobin types, and affected by motion artifact. Question. What are the phases of capnography? Answer. Phase 1 is dead space gas. Phase 2 is the transitional phase. Phase 3 is the alveolar plateau. And Phase 0 is inspiration. Question. What are the causes of increased end-tidal carbon dioxide? Answer. Causes include hypoventilation, increased carbon dioxide production as seen in malignant hyperthermia or fever, and administration of bicarbonate. Question. What are the causes of decreased end-tidal carbon dioxide? Answer. Causes include hyperventilation, decreased carbon dioxide delivery as seen in pulmonary embolism or cardiac arrest, and circuit leaks. Question. What are the challenges of one-lung ventilation? Answer. Challenges include hypoxemia due to increased shunt, higher airway pressures, and inhibition of hypoxic pulmonary vasoconstriction by anesthetic agents. Question. What are the considerations for anesthesia in patients with chronic obstructive pulmonary disease? Answer. Avoid nitrous oxide to prevent air trapping, permit increased carbon dioxide levels, and use low positive end expiratory pressure to avoid auto-positive end expiratory pressure. Question. What are the perioperative risks for patients with obstructive sleep apnea? Answer. These patients have a higher risk of airway collapse, increased sensitivity to opioids, and increased risk of postoperative respiratory failure. Question. How is pulmonary hypertension managed? Answer. Management involves maintaining right ventricular preload, avoiding hypoxia and hypercapnia, and using inhaled pulmonary vasodilators. Question. What are the features of smoke inhalation injury? Answer. Smoke inhalation results in airway edema, carbon monoxide poisoning, and possible cyanide toxicity. Question. What are the clinical features of fat embolism syndrome? Answer. Fat embolism syndrome presents with hypoxemia due to ventilation-perfusion mismatch, neurologic symptoms, and a petechial rash. Question. What are the causes and treatment of intraoperative bronchospasm? Answer. Causes include endotracheal tube obstruction or anaphylaxis. Treatment involves deepening anesthesia, administering beta-2 agonists, and using epinephrine. Section 5. Advanced Concepts. Question. What is the physiology of nitric oxide? Answer. Nitric oxide is a vasodilator produced by the endothelium and is used therapeutically for pulmonary hypertension. Question. What are the principles of gas exchange in extracorporeal membrane oxygenation? Answer. Venovenous extracorporeal membrane oxygenation provides oxygenation only, while venorterial extracorporeal membrane oxygenation supports both oxygenation and circulation. Question. What is apneic oxygenation? Answer. Apneic oxygenation refers to the continued diffusion of oxygen during apnea as long as the airway remains open, allowing adequate oxygenation for 8 to 10 minutes in adults. Question. How are ventilator graphics interpreted? Answer. Flow volume loops are used to detect airway obstruction, while pressure volume loops assess lung compliance. Question. What are the principles of high-frequency ventilation? Answer. High-frequency ventilation uses very small tidal volumes at rates from 120 to 900 breaths per minute, reducing the risk of barotrauma. Question. What information does a pulmonary artery catheter provide? Answer. Pulmonary artery catheters measure pulmonary artery pressures, pulmonary capillary wedge pressure, and cardiac output using thermodilution. Question. What is electrical impedance tomography? Answer. Electrical impedance tomography enables bedside regional monitoring of lung ventilation. Question. What are the key signs detected by lung ultrasound? Answer. B lines suggest pulmonary edema, while the presence of lung sliding excludes pneumothorax. Question. What does near-infrared spectroscopy monitor? Answer. Near-infrared spectroscopy provides non-invasive monitoring of cerebral and renal oxygen saturation. Question. What is extracorporeal carbon dioxide removal? Answer. Extracorporeal carbon dioxide removal uses low-flow extracorporeal membrane oxygenation for managing severe hypercapnic respiratory failure. Section 6. Critical scenarios. Question. How is a malignant hyperthermia crisis managed? Answer. Treatment includes administration of dantrolene at 2.5 mg per kilogram, increasing minute ventilation, cooling, and treating arrhythmias. Question: what are the clinical signs and management of tension pneumothorax? Answer: signs include decreased breath sounds and tracheal deviation. Immediate management requires needle decompression. Question: what are the respiratory signs of anaphylaxis? Answer: anaphylaxis presents with bronchospasm, increased airway pressures, and hypoxemia. Question: how is pulmonary edema treated? Answer: treatment comprises diuretics, positive and expiratory pressure, and afterload reduction. Question: what are the features and management of air embolism? Answer: air embolism causes decreased end-tidal carbon dioxide and a millwheel murmur. Management includes hyperbaric oxygen therapy. Question: what is the difficult airway algorithm? Answer: the algorithm recommends calling for help, followed by face mask ventilation, use of a supraglottic airway, endotracheal intubation, and if these fail, surgical airway intervention. Question: what is the management of aspiration pneumonitis? Answer: the use of steroids is controversial. Bronchoscopy is indicated if particulate matter is present, and antibiotics are used if infection occurs. Question: how is status asthmaticus managed? Answer: management includes permissive hypercapnia, ketamine infusion, and extracorporeal membrane oxygenation if refractory. Question: how is carbon monoxide poisoning managed? Answer: management involves administration of 100% oxygen, hyperbaric oxygen therapy if severe, and recognizing that carbon monoxide causes a leftward shift in the oxygen dissociation curve. Question: what is the management of drowning? Answer: drowning is managed using the acute respiratory distress syndrome protocol, avoiding steroids, and utilizing extracorporeal membrane oxygenation if refractory. Thank you for tuning to today's podcast. If you enjoy the content, please like, share and subscribe. See you next time on the Everything Surgery podcast.